everyone, and welcome back to Money Power Health. This week, I'll be speaking with Martin McKee on conducting public health research, maximising the impact of collaborations, engaging with the media, and much else besides. Martin is Professor of European Public Health at the London School of Hygiene and Tropical Medicine, a past President of the European Public Health Association, a past Chair of the UK Society for Social Medicine, and many other things besides. He is a member of the UK Academy of Medical Sciences and the US National Academy of Medicine. He's currently the President of the British Medical Association, the trade union and professional body for doctors and medical students in the UK. When introducing someone like Martin, it's easy to dwell on his titles, achievements, publications, on what he's done, and forget who he actually is. When I attended my first lecture at LSHTM, I had no idea who the lecturer was, or even what public health really was. Yet by the end of that lecture, which spanned the history of public health to the widening understanding of the role of social, political, and commercial forces that shape it, its links to social justice, I was absolutely transfixed. I knew in that moment that public health was what I wanted to do. So I have to give credit to Martin because he was my teacher that day and made a huge difference to me personally. I hope you find this conversation interesting, and as always, if you have any suggestions for future guests, please don't hesitate to drop me a line. Martin McKee, welcome to Money Power Health.
A pleasure.
So Martin, I have to confess that you were quite a hard podcast guest to do research on and prepare for, because when I looked at the breadth of your outputs, it was a bit like whack-a-mole in terms of critical subjects in public health, medicine and society, everything from the collapse of the Soviet Union, the health impact of the Great Recession, the effects of harmful products, the effects of macroeconomic change, political decisions like Brexit, and everything in between, all the way down to biomarker levels and risks for particular disease outcomes, and all the way up to global trade. So I thought I might start by asking you how you would define yourself and your research interests.
Yeah, I think I often say that I'm undisciplined and unfocused in that I work with people from a very broad range of disciplines. I think you are, if one is dealing with some of the big challenges that face society, you have to do that. So I started off my career looking at the health effects of the collapse of the Soviet Union, and then moved on to work on the global financial crisis, and more recently on COVID and on Brexit. And if you're trying to understand something like that, you need to really go all the way from the basic biology, the physiology, the pathology that is leading to people becoming ill, right through to the causes of the causes of the causes, to expand on what Michael Marmot has said. Maybe I could give you an example. If you look at what happened in the former Soviet Union, we saw these really unprecedented fluctuations in life expectancy, never seen before in peacetime. And we were trying to understand that. It soon became clear that alcohol was involved, but it wasn't just vodka. It was actually eau de cologne's aftershaves that people were drinking. So we had to do some work which involved analysing those alcohols. Interesting stories of taking them in my baggage from Russia to my colleagues in Hungary, where we've been looking at the content and the pathological effects of some of these alcohols, to understand it, doing work with pathologists who were doing autopsies to understand the pathological mechanisms for the sudden cardiac death, because at that time people were saying that alcohol was cardioprotective, all the way through to the political science insights to look at the way in which very rapid economic, social, political change was driving people into hazardous behavior, particularly in that case, heavy alcohol consumption at a time when the alcohol was widely available. So that involved working with colleagues from pathology, from biochemistry, through to political science, through to geography, a very wide range of people. And that meant that we were able to get a fairly comprehensive picture of what was going on. And I've applied that principle to my work ever since.
This is really fascinating to me, Martin, because what you're describing is both very kind of familiar to me in the sense that I can see now how you've applied that broad lens to other issues. And that certainly explains the diversity of collaborations and nature of papers that you've written. But it also strikes me that we in public health are kind of incentivized away from that kind of thing. You know, if I'm writing a grant, my chances are improved by being a specialist in the methodology and perhaps in the subject area. And certainly when I was working at LSHTM, I often felt that a lot of my colleagues were quite specialized, specialized epidemiologists, specialized on a particular disease or discipline. Do you feel that, that kind of generalist approach is sufficiently incentivized? And, do you feel that's part of what maybe more people are lacking?
I think it's strongly disincentivized, unfortunately. And one hears far too many accounts of emerging up-and-coming researchers who are told that they must specialize in a particular area. They must be identified as an independent researcher. And yet, if we are dealing with the complex challenges that face society, we have to work collaboratively. Now, we do need specialists. We absolutely do need the expertise in, clearly I'm not going to be doing the laboratory work myself. I did actually start off my career as a junior doctor doing work in laboratories. And funnily enough, some of that work was on peptide biochemistry. And we returned to that in some of our work in Russia, but that I think was more coincidence. But I think what is important is that within any institution or within any team, there are a few people who are broad generalists who have enough understanding and respect for the different disciplines. It doesn't mean that I can do the detailed econometrics or the laboratory work that is needed, but at least I can grasp the principles and I'm able to often challenge. And I think I've seen this particularly in work with my colleagues doing econometrics, where you will find a relationship like, for example, an apparent rapid change in deaths from cancer. And the role of somebody like me is to say, well, actually, if you see that, it must be a data artifact. It just is not biologically plausible. And that led us, in fact, down an area of work where we actually saw some of these very rapid changes, papers we published in Croatia and in the former Soviet Republic of Georgia, where there were huge changes, and it pointed us towards the anomalies in the data, and we were able to dig back and look at that. So I think having that discussion and saying, well, this is an interesting finding, but it's incompatible with the biology or it's incompatible with something else, then bringing that together, I think, is an important contribution. But I absolutely am not criticizing the role of specialists. I think the danger is whenever they are in their own echo chamber, and you do see in a number of these areas papers that are published that clearly, had they been discussed a little bit more widely, they would never have got through they would never have come to fruition.
No, absolutely. It's really worth thinking about in terms of how we approach incentives and in teaching and research in public health, because it strikes me that there is definitely a role for specialist knowledge, but you do need that generalist perspective. And I suppose one of the ways in which you've demonstrated the value of that is in speaking out and making the case for public health and holding people to account, be that politicians, as I've noticed in recent years in particular, but also fellow doctors or members of the media. And that almost requires an even wider broadening of the lens beyond academic disciplines to what evidence is doing out in the world and whether it is or isn't being considered by decision makers or the media. How do you manage that aspect of your work, like paying attention to how public health is or isn't being acknowledged in political decision making or in the media?
Well, first of all, I think that if you are doing publicly funded research, you have a responsibility to make a difference. I do accept that there are areas of research that only will have the importance of them may only become apparent many, many years later, like pure mathematics, for example, or perhaps some areas of subatomic physics. I'm not picking in those in particular. And the practical applications or the policy applications may not be immediately obvious, although that doesn't mean that we shouldn't do them. But I think if you're working particularly in public health, there is, I think there's, why do we do this if we're not actually trying to make the world a better place? We could go off and do other things. And for me, I go back to my, why did I come into public health? Because I trained in medicine. I qualified relatively early. I got my specialist examinations, my membership of the Royal College of Physicians at a relatively young age. And at that time, I was being pushed into an academic medical career, which essentially was laboratory work. Now, that laboratory work, as I say, is important, but it wasn't really engaging with the problems I was seeing in my clinical practice, which was in West Belfast, one of the most deprived areas of Western Europe. And there I was seeing patients with scurvy and beriberi in the 1980s, people who were suffering from really severe disadvantage. And I think I've always had a very strong view that the research that I should be doing should be helping people like that, and increasingly internationally, to be able to break away from the cycle of desperation leading ultimately to the deaths of despair that we see. And I've seen people who are being left behind, people who are living dreadfully precarious existences. And that may be in the former Soviet Union in the wake of the collapse of communism. It may be as a result of the global financial crisis. It may be as a result of the COVID pandemic. So there's a theme running through there. But a lot of my work, while some of my work has clearly been at a population level, doing large-scale ecological studies, looking at countries as the unit of analysis, quite a lot of my work has also been involved, has engaged with co-design, co-production, understanding the lived reality for some of the people who otherwise have no voice. I'm a great believer in public health having a role in making the invisible visible, be it their invisible problems or invisible people who are often ignored. So that's why I think we do this. Now, if you do that, then there's no point. It's not enough to just do the research and publish in an academic paper. You've got to do something about it. And to my mind, the academia has a role in a democratic society, like civil society does. It's not just the legislature, it's not just the formal structures, but there's an agenda-setting role there. It's to say, hold on a minute, you're overlooking people who are being ignored, in some cases tragically, by the design of the democratic structure in countries where there is voter suppression, for example, or people are undocumented migrants and others who don't have any voice. And I think that we have a responsibility to speak out on their behalf with them and give them a voice.
Absolutely. Gosh, so many thoughts are coming to my mind just as I heard you say that. I mean, one area I wanted to talk with you, I mean, you're currently involved, obviously, in the BMA, which is the trade union and professional body for doctors and medical students in the UK, for those of you who might not be aware. And I wanted to talk to you about how you've navigated sometimes tension between public health and medicine. When I was in the US on my Harkness Fellowship, I felt this very acutely, that medicine really held a lot of the power in discourse around health in the US. And it was really striking to me how I could take a short bike ride from Roxbury, which is the predominantly black, extremely impoverished part of Boston, where median household wealth might be less than $10, to a huge, shiny hospital, Brigham and Women's, which had revenue that exceeded the annual budget of the WHO. And, you had a whole load of doctors and medical specialists and almost a medical industry in the US that was really in the ascendancy. How have you managed to balance that tension in your own work, in both holding doctors to account about the wider forces that shape health, but also working with them to maximize their positive impact?
Well, first of all, I would say that I think the United States is a complete outlier in in the world, but particularly in the industrialized world, in having that medical industrial complex. Now, you do see elements of it elsewhere. So, for example, there are some doctors who do engage in activities that are adding very little to the sum of human the health. They might be improving happiness, perhaps some of the cosmetic surgeons, but not particularly to human health. But that's another debate. But I think that in the United Kingdom, we're fortunate in that doctors do understand that they are often picking up the pieces of failures in other government policies. And that is actually a major thrust of the current campaigning by the BMA. It is a professional body. It is concerned about the wider implications of the wider health of the community. And it is cash limited. It has suffered from long-term underinvestment. And doctors are exhausted, particularly after the COVID pandemic. So it's not just enough to keep working harder and harder. And in fact, there are constraints on doing that because we've seen long-term capital underinvestment. We don't have the equipment. We don't have the facilities. The hospitals are literally being held up by wooden props in one case in the constituency of one of our more recent prime ministers.
Gosh.
And we can't go on like this. So we have to actually hold the government to account for the policies that it is enacting that are making people ill. Now, of course, we're ready to treat people when they do become ill. But if doctors are exhausted, if doctors are leaving the profession, then there'll be nobody left. So that's why I think we have to engage with those wider policies. Also, I think if we go back maybe 30, 40 years, there was much more of a division between medicine and public health. And that was part of the rejection. I mean, there were people writing in the 1960s, Thomas McKee in particular, who argued that medicine contributed very little to population health. Now, of course, he was writing at a time before we had modern medicines, the beta blockers, the ACE inhibitors, and so on, that revolutionized the treatment of cardiovascular disease, the drugs for common mental disorders and for various other things that have really changed the situation entirely. Ivan Illich, writing at that time, argued that medicine wasn't just useless, it was actually harmful. But I think we have changed a lot. And as you know, Ellen Nolte and I developed, we refined from earlier work by Walter Holland and others, Rob Stein in particular, a measure of avoidable mortality, death that should not occur in the presence of timely and effective care. Now, our measure has now been incorporated into the global burden of disease and by OECD, the Commonwealth Fund, and many others. And I think what that has demonstrated is that at least in the last 20 or 30 years, medicine has made a substantial contribution to the improvements in population health. But of course, we need to make sure that everybody has access to high quality care. Just having it there it won't be enough. So I think that the dichotomy, the divisions that were there before have to a large extent broken down, at least in Europe. And I think also in many other parts of the world. And we're able to benefit from that. I also find that the professional leaders of the Royal Colleges and others, and also as physicians become more senior and they look around them, they do recognize the importance of the broader determinants of health. But I think we are helped by the financing system we have in European countries.
No, that's a really interesting point, Martin. And I think the difference between the way you describe the position of doctors in the NHS system to the position they occupy in the US system, at least as I experienced it, is really quite striking. And I suppose it's a reflection of some of the deeper effects that these different types of health system organization have in terms of how we think about health as opposed to healthcare. Another, I think, quite powerful force that shapes how the public think about health and its causes is the role of the media. And I wanted to raise this with you, both because it's a topic you've spoken on in recent years and taught about, but also it's a topic you actively live. You're quite active on media. You have been throughout the COVID pandemic, but also before in discussing the impacts of, say, Brexit or of NHS reform in years previous. And so you've seen how the media has or hasn't covered health topics with nuance. And I wanted to ask you on your perspective on this, because it seems to me that in some ways the media is a big part of the problem, either in drawing attention to relatively spurious studies and impacts on health, or being quite black or white about the consequences of particular decisions.
It's very difficult, isn't it? Because there are some parts of the media, and this is not a political issue, because there's very good reporting from the right and left, at least on either side of the centre anyway, not the extremes in all sides. And in the United Kingdom, I think you've got very good reporting in both The Guardian, the Financial Times in particular. Financial Times has done a really excellent job. And and also there are many good examples internationally as well, where the reporting has been very responsible. Sadly, we do have some outlets that are essentially peddling disinformation. And my colleague Ben Goldacre at one stage had a website, had a collection of links to, he argued that one of the British daily papers was collecting a list of almost everything, every animate and inanimate object in the world, and having stories that it was both a cause of and a cure for cancer. And this was simply feeding, it's clickbait. It fills the pages, but it's unfortunately nonsense. I think it would be there is, I think, a problem with the engagement of some of the journalists. I think one of the difficulties we have to recognize is that many media outlets have really cut back on their reporting budgets, and as a consequence, what happens is that we get what's called churnalism, churning press releases, where one takes a press release from somebody or other, and then one phones up a few scientists, and I'm one of them that they occasionally phone up, and they look for a quote to pad out the press release, but it doesn't go further than that. I think the budgets have really cut back on the potential to do the really good investigative reporting. There are outlets, I think, I will mention one of them, Byline Times, that is doing good investigative journalism, and there are some other teams that do that. But unfortunately, it's quite difficult to make that model work financially.
And it strikes me that related to that, and something you've written a lot about, is the lack of focus or attention on interventions that are potentially massive for health. I mean, you and I wrote a short piece on the mini budget in the BMJ, and how it was a consequence of really foundational commercial forces with major impacts for health. Like you said, we're about to have another statement, which itself might have huge implications for health. Brexit, obviously, is another example. It strikes me that some of these issues, they really don't feature as much in health coverage versus acute crises related to, for example, NHS capacity. Do you think that feeds into that wider issue to do with reporting, or does it also reflect a sense that while we in public health and medicine might have a now well-established sense of the social determinants of health, that hasn't necessarily pervaded in public discourse and understanding?
I think sometimes it's difficult to tell the story, because it's very clear that if somebody stands in the middle of the road and they get knocked down by a speeding car, the cause and effect relationship is very obvious. But then when you look at the impact of some of these major changes, where it will feed through into changes in people's lifestyle, their living conditions, the choices they can make, and then ultimately into their health. But teasing all of that out is always very difficult. And it's so easy for those people who want to pretend that this is not an issue to say, yes, but what about this? What about that? I think that there's quite a lot that you can do with natural experiments. My colleague David Stuckler in particular has been a great advocate of this, and we've done quite a lot of work where you can take groups that are exposed in different ways. So, I mean, for example, a study we did which looked at the introduction of the minimum wage in the United Kingdom, and that we were able to look at people who were just below the threshold so they would benefit, and those who were just above so they wouldn't benefit, and compare the changes in their health. And we showed that even earning perhaps £1 more each week actually had a significant impact on their health. So there are clever sort of imaginative things you can do with particularly with some of the methods of analysis that we have. But I think that one of the problems is that often many of these things are just not spoken about anyway. And you mentioned Brexit. There is this rather bizarre situation when I think any objective observer will note that Brexit is at the root of many of the country's problems. Clearly, the economic damage that it has done. A story in the newspaper today of a cheesemaker whose business has folded and is being taken over by a group in the Netherlands because it's just impossible for small and medium enterprises who were exporting to the rest of the EU to continue anymore. And yet we have almost a sort of omerta here, a silence by both of the main political parties that are not challenging this at all. And often one hears, particularly in the BBC, when somebody does raise it, they're told that, well, we're not going to revisit that. It's a done deal. And yet, that this is dragging the economy down. It's also having an impact on health. So there's just no discussion of it. And I think that's one of the concerning things, that there are areas that are just off limits for discussion by those who have an ability to control the agenda. But I think a lot of it is complicated to tell these stories, to make all the connections, because again, we've seen that very much in the last few years. As I say, we know that Brexit has done immeasurable harm, but it's been caught up in COVID, and the British government has been able to say, well, it's all to do with the pandemic, even though, of course, some of it was due to the pandemic. Some of the failure to respond adequately to the pandemic related to our breaking of links with the rest of Europe anyway. But you can blame the consequences for trade on the pandemic, and now they're blaming the war in Ukraine. And there'll always be something else they can blame, but if you're determined to avoid the elephant in the room, then it's very easy to do that. And then the media follows that. I think one of the problems we also have with the media in the UK is almost like a Faustian pact between the political reporters, who are so dependent on getting leaks and stories from the senior politicians. And therefore, although there's an appearance that they're challenging them on some things, there has to be some sort of an appearance there. In reality, there's a sort of unspoken agreement that some things will not be talked about, and I think that doesn't help. And I think it's unfortunate, particularly in the pandemic, when we saw that much of the reporting was being undertaken by the political reporters rather than by the health reporters. And particularly in the case of the BBC, I think again this rather unhealthy relationship between some of their senior reporters and politicians, because they're mutually dependent on each other.
Yeah, no, you're absolutely right. And I suppose that is just another form of power, isn't it? That kind of power over the media based on that mutual dependency, and more widely, the media's power to shape discourse and public understanding of health issues. I suppose that links to another question I wanted to ask you, which was how you navigate the tricky tension between wanting to provide an evidence-based position and something to contribute to the public sphere in the media, while not appearing party political necessarily or partisan, but without also sacrificing one's own ideology or position. That's quite a difficult tension. That is a very personal decision that each scientist has to manage in different ways. But I just thought I'd ask you on your perspective on it, because you have in the past taken quite forceful positions, not necessarily based on party political orientation. So I just wanted to ask you to reflect on that, if I may.
Well, first of all, I think we do have values, and whether you call values ideology or not, I basically put my cards on the table. I believe in fairness. I believe in what Michael Marmot and others have called progressive universalism. I think nobody should be left behind. I'm a great believer in the philosophical approach of John Rawls, which is that we're not trying to create a fully equal society, because that doesn't work. You do need to have incentives for people to succeed, but you should always have a society in which nobody is completely left behind and people should have opportunities. I'd like to think that I'm somewhere in the center of politics, but of course the difficulty is that politics have moved greatly during my lifetime. We sometimes talk about the Overton window, which is the range of acceptable policies, and I think back to when I was born, you had Harold Macmillan, in power as a Conservative Prime Minister whose boast of his greatest success was having built hundreds of thousands of council houses. Well, you wouldn't get a Conservative Prime Minister saying that now. Of course, he was shaped philosophically by and ideologically by his experience in the First World War when he was in the trenches with his soldiers, and by what he saw in the area that he came from up in the northeast. So I think politics has changed a great deal, and there is at least currently this move to, in some cases, a more ideological approach based on identity politics. But it's paradoxically, even though there are parties that would be described as right-wing, not necessarily, there's a mix of economic liberalism and conservatism there as well. I think we're seeing a focus on almost a subtext of nationalism and populism and so on. But sometimes, as in during the COVID pandemic, introducing economic policies which have a very high level of state intervention. So it's all a bit mixed up. And it's difficult to know where one lies in, as the politics is changing around one. I'm always reminded in this of the apocryphal story of the old woman in the Austro-Hungarian Empire who'd lived in 4 different countries without ever moving from her village as the borders moved around her. And but I think I've been critical of governments of all complexions. And I was heavily critical of the communist regimes in Eastern Europe in the same way that I'm heavily critical of the extreme right-wing populist parties at the minute. And but I think you've got to look at what works. There are some of the things which I've looked at and been favourably impressed by that many people on the left would not be. I'm thinking of welfare to work, the value of work in its own right. Not just replacing people's income. Well, some people would criticize that, but it seems to me the evidence is good there. So I think, but I'm not pretending that I'm not shaped by my values. Of course I am, and that probably goes into ideology at some stage. But one of the things I'm absolutely defiantly clear about is I am not party political. I've never been a member of a political party, and I know members of Parliament in all the main political parties, obviously not the Brexit Party and some of the extremist groups like that, or some of the ones in Northern Ireland. But I think it is important for someone in my position to avoid party politics, but also to engage with what I believe to be good people wherever they are.
I really like that, Martin. I think working with good people wherever they are is quite a good tagline to live one's life by as a researcher. And yeah, really appreciate these quite candid reflections. I hope I'm not prying too much by doing so. I feel that linked to this idea of working with good people wherever they are is a question I wanted to ask for those listeners who are earlier on in their careers in research, in advocacy, or just in any form of work related to health. It strikes me that you have had a unique ability to build a huge number of relationships and partnerships, not just with political leaders like you just mentioned, but with fellow researchers. You've collaborated with a huge number of people over the years in all kinds of different settings at all kinds of different levels of seniority. And for someone starting out in research or in any other sphere of work related to health, I thought it might be quite nice to ask you, what is the secret to building those relationships? What is the secret to being a good collaborator?
Very good question. Well, first of all, I think it's incredibly important. And I always find this sort of paradoxical in that some academic colleagues are advised to, work individually, develop your own specialty, as if this will in some way give them some measure of academic success. But if you look at I'm not going to get into the details, but if you look at the conventional metrics, it just simply doesn't work that way. If you are concerned about metrics, and it's easy for me to say that I'm not, because I do modestly rather well on them, the way to do it is to work collaboratively. The other thing is, it's part of one's job satisfaction. I think it's fair to say that I've I mean, you can comment better than me, but one of the things I've prioritized in my work has been mentoring early career researchers and other colleagues and supporting them. I'm incredibly proud of the people that I have supported. I now have there are now, I think, 6 professors in our faculty here at the school, all female, interestingly, who are my former PhD students, and I'm incredibly proud of them. But I'm particularly proud of the fact that I've seen how they are now mentoring another generation, and that gives me great satisfaction. I work with colleagues in many different countries, and I'm privileged to work with them, to support them. We both benefit from the interaction because I learn from them. Hopefully they learn something from me. So I just find it incredibly enriching. The other thing I should say is that I think often in the United Kingdom, there is a tendency not to be a bit cautious about engaging with, let me just call them, foreigners. And I've seen this very often where, and I hope people won't take this wrongly, where the British delegations, for example, or British researchers are always talking to themselves or talking to the Americans and not engaging. You know, I was recently in my BMA role at the World Medical Association meeting in Berlin, and I was privileged to have conversations with, I think, all but 1 or 2 of the delegations that were there. And what was really nice was that I found that in every case, even if I didn't know the individuals in the delegation, I knew somebody from their country. And that proved incredibly valuable. It is also really important just in terms of doing international work. And I've joked that, I won't say who, but some of my colleagues who do international work see countries as dots on a scatter plot and are not maybe necessarily clear about the context. I don't know how you can actually understand a country without knowing its history. Now, this is a bit of a hobby of mine, and for example, I've given talks before that looked at public health through the lives of the Habsburg emperors, or when I was getting an honorary degree in Greece, I wove in the stories from the Greek myths and Thucydides and the histories of the Peloponnesian Wars and so on. And I think that's quite nice because it helps you to understand what's happening. I would also say that there are some countries where you cannot meaningfully engage if you don't understand the history. I think the United States is one. I'd pick out Hungary as another, with the legacy of the 1919 Treaty of Trianon, which has been hugely influential in the national psyche. Russia, clearly another one, and Ukraine, countries that I've worked in a lot. So I think knowing people from the countries, being able to engage with them, having friends and colleagues, and many of my closest friends, in fact, most of my closest friends actually are from outside the UK, I think has benefited my work immensely. I hope that they've derived some benefit from it. But in particular, I think I look at my collaborations with younger people and my pride in that, including you, Nathan, who have done incredibly well. And, that's what we leave. It's not the papers. It's not the other stuff. I mean, the legacy is individual people. And that I think gives one tremendous satisfaction. That all sounds a bit pious, I know, but it's true.
No, not at all, Martin. Certainly, I've had the great privilege of meeting people quite early on in my career in public health who I very much aligned with and gelled with, and being able to do work that I believe in with people that I admire and respect so much is one of the great joys, unexpected joys of this journey so far. And another one has definitely been seeing students that I've taught along with others graduate and go on to do amazing things that I couldn't do, but things that have a really amazing impact on wider society. And just thinking about that and hoping to keep doing that is a really positive thought to end on. So thank you so much for your time. It's been a privilege talking to you as always, and best of luck with all you're doing in research, policy, and in your role at the BMA. Take care, Martin, and thanks for joining us on Money, Power, Health.
Well, thank you very much, Nathan. It's been a pleasure talking to you.
Well, that does it for this episode of Money, Power, Health. Thanks as always for joining me. I look forward to sharing future episodes with you in due course. If you do get a chance, please consider leaving a rating on whatever podcast app you're using, as that really helps other people locate the podcast. Thanks, and I'll see you next time.